Can everyone make sure they have their mics muted? Okay. Are you ready to get started? You guys aren't very talkative tonight. Okay, so if everyone's good, let me know if you need me to repost the link to sign in. But I'm going to start with the gait cycle. I'm going to try to keep this fairly short tonight because I know everyone's kind of, it's crunch time for the block exam Monday. So I'm going to try to keep this around 45 minutes or so, hopefully. Okay, so a lot of these slides, like most of these slides, came from Allie because they were just so good. I added in a few of my own slides here and there, and I went through and I know since we're getting close, I put stars next to everything that I remember being a question from last year or based on like listening to the lectures again, just picking up like on those subtle hints. So hopefully that helps. I'm going to go through the gait cycle fairly quickly. Okay, so I've had a lot of people message me about the gait cycle, kind of freaking out about it. So I have good news and bad news. The bad news is you do need to know this for the test. Like he is going to test you on the specifics of it. But the good news is you're not expected to know this next year. So in second year, they just focus on pathologic gait. So if this is something that you need to cram and dump, feel free to do that. Okay, so my advice for this, and just for the sake of time, I'm not going to go through and read this to you, but how I approached this was, first of all, so learn the name of each phase and decide if it's in the stance phase or the swing phase or so on, and then approach it by learning which group of muscles are engaged during that phase. So for example, during the heel strike phase, you're engaging the anterior compartment of the leg and then also the hip extensors. And then in the loading response, you're engaging the anterior compartment of the thigh and then the posterior compartment of the leg. So if he asks a question, like which muscle is engaged during, the loading response, then if you at least know the compartments that are working in that phase, then you should be able to get the question right. So don't go too crazy or get too specific with this. If you know what's in his slides, you'll definitely be able to answer his questions, so don't feel like you need to go to the textbook or anything like that. Okay, so long story short, learn each stance, learn A, B, C, learn the names of them, and then learn which muscle group is working during that stays. So like Allie did an amazing job with these slides, so hopefully if you go through this, this should help you learn it really well. And this is more than enough to get his questions right, what she has here. Okay, so gait abnormalities. I don't remember him testing specifically on any of these. So these are more for when you get to neuro and second year, of course. But this one, you definitely need to know. I think this has been brought up like at least a couple times in a couple different lectures, so that's probably a big hint that he's going to ask about this. So if you have an injury to the superior gluteal nerve, first of all, know which muscles are being affected. So you want to know that the superior gluteal nerve innervates the gluteus medius, minimus, and the TFL. And then if you have an injury to this nerve, your patient is going to present with what's known as a Trendelenburg gait. So this is what they call a buzzword, they're not going to use this word in a question stem. Instead, they're going to describe how the gait presents. So you can call it a waddling gait, but two important points here and here is that injury to the superior gluteal nerve results in contralateral hip drop. And then the patient is going to try to compensate for that by leaning their trunk to the affected side. So if you see a question stem that describes contralateral hip drop and an ipsilateral lean to the affected side, they're talking about Trendelenburg gait, and that's an injury to the superior gluteal nerve. So super high yield to know this one. Is everyone okay with that? What nerve innervates the gluteus maximus? Right, good job. Good job. Yeah, don't let that trip you up. Okay. So another star. This one is also very important. So if you have an injury to the common fibular nerve, so branching off the common fibular, you have a superficial and a deep fibular nerve, and your deep fibular nerve is going to innervate the anterior compartment of the leg. So if you lose innervation to the anterior compartment, you've lost innervation to your dorsiflexors. So you're not going to be able to dorsiflex the ankle, and you can't clear the toes off the ground. So this is going to lead to what's known as a steppage gait. So basically, the patient is going to flex their hip and knee up very high so their toes can clear the ground, so they don't trip, basically. So if this is confusing at all, I definitely suggest YouTube and just Google patient with a steppage gait, and you can see how. Yeah, it would. And honestly, during second year, they're going to teach you that steppage gait is directly related to the deep fibular nerve. I'm not sure why he's not doing that here. I guess he maybe is trying to keep it a little bit more simplified. But yeah, if you had an injury to the common fibular nerve, you would have more deficits than just dorsiflexion. But I'm trying to just go along with what he said. That way it doesn't cause any confusion. Like I'm not, I'm not going, I don't want to go against what he's saying. Does that make sense? So for now, no common fibular. But if you see deep fibular as an answer, that would be like the most correct answer because that's specifically affecting your dorsiflexors. And then, so these two, I think using this picture was a little bit confusing. Okay, so swing out gait, this is often a result in stroke patients, and then waddling gait is due to pelvic instability. So for this exam, you really just need to focus on A and D. So A is going to lead to D. So hopefully that's clear. Okay. And then, another important thing to understand is where the common fibular nerve wraps around the neck of the fibula. So if he shows you an x-ray with a fracture to the neck of the fibula, you need to associate that or, think, oh, the common fibular nerve is probably injured, and then what's going to happen. So that's one way he could test this, is to show you an x-ray with a fracture to the neck of the fibula. Okay, so my advice for this lecture, no steppage gait, no Trendelenburg, and then you're probably going to get 1 to 2 questions about the specifics of this. So unfortunately, it's really just memorization. Okay, so limb development. So, in my opinion, Dr. Gassler is kind of notorious for um, using a lot of slides to make not that many points. So I think this has narrowed it down to like 8 or 10 slides, and it's pretty inclusive of like everything that was in his lecture. So like I went through, like I listened to the lecture that he gave this year, and I went through and I made sure everything was in these 8 or 10 slides that that he covered, or I felt like was really important to know. So I feel really confident that if you know these next 8 to 10 slides, like you're gonna be fine on limb development. Okay, so I would focus on the red boxes on this slide. So you've already been tested on the notochord and the development of the spinal cord. But just a reminder here that the notochord is forming the nucleus pulposus, and then you have the annulus fibrosus around it. So just in case. And then the intermediate mesoderm, that's giving rise to all of your Golgi organs. So this was covered last exam. I wouldn't worry too much about it. Your focus needs to be here and here. So paraxial mesoderm is going to give rise to somatomeres, which form 42 to 46 pairs of somites. And then these help form the axial skeleton. So the somites are going to migrate to each of these regions. And then your lateral plate mesoderm is going to give rise to a somatic mesoderm and a splanchnic mesoderm. So the somatic mesoderm is forming the limb buds. And then around week 6, so on the last exam, did he get very specific with the weeks or days? Yeah. Okay, good. So that trend should continue. So if you see specific days or weeks, don't worry too much about it. Just have a broad idea. So in limb rotation, okay, so right here and right here, extremely important to know. So your upper limbs are going to rotate 90 degrees laterally. And this results in your flexors being located anteriorly and your extensors being located posteriorly. So unfortunately for this lecture, like you are going to need to remember a little bit of upper limb. So remember your flexors are in the front and then your extensors are in the back. And in the upper limb, what nerve is getting most of the extensor compartment? Right, the radial. And then how about the flexors of the forearm? Median, good job. And then the flexors of the arm. So what nerve is piercing the coracobrachialis? Yeah, musculocutaneous. Good job, you're on top of it. So that is about the extent that you need to remember upper limb. Okay, so just be able to broadly group the brachial plexus based on compartments, and that should get you by for this lecture. I mean, ideally, you're gonna remember every detail, but I get it. So if you can at least remember that much, you should be okay. So then in the lower limb is going to rotate 90 degrees medially, and this is going to put the extensor compartment anteriorly and then the flexors posteriorly. So notice the difference here. Okay. So your somites are going to divide into a sclerotome, a dermatome, and a myotome. The dermatome and the myotomes are coming from the dermatomyotomes. And your myotome, okay, so notice all the stars. This is a big hint. So I think we at least had 2 questions about this down here. Okay, so you got to know this. All right, so myotome is going to divide into an epimere and a hypomere. And the hypomere gives rise to your hypaxial muscles, which are forming the ventral body wall muscles. And these are innervated by anterior primary rami. And then the epimere gives rise to epaxial muscles, which form dorsal body wall muscles. So these are innervated by posterior rami. And on the ventral side, okay, so this is where the test questions are going to come from. On the ventral side, the upper extremity and the lower extremity. So the upper extremity, the anterior condensation, is going to give rise to your flexors and your pronators. And then your posterior condensation is going to give rise to the extensors and the supinators. So on top of that, you also need to be able to associate what chords of the brachial plexus are associated with the anterior condensation versus the posterior condensation. Okay, so up here, a little review, the posterior chord of the brachial plexus is going to give rise to what two terminal branches? I know this is going way back, but yeah, axillary is one. Not median. Think about, yeah, right, radial. Awesome. So axillary and radial nerve are the two nerves associated with the posterior cord. So what is axillary nerve innervating? Deltoid. Yes, teres minor. Good job, you guys. Okay, so like I highly recommend just spending like 20 minutes like doing a little like quick review of the brachial plexus. You know, don't need to know it's super detailed, but just like the main points, like get that back in your head. Okay, and then the lower extremity, the anterior condensation, gives rise to flexors and adductors. And then the posterior condensation is going to give rise to your extensors and abductors. All right, so everything in this red box is very important for you to know. Okay, so where this slide is coming from, so your sclerotome via endochondral ossification is going to give rise to bony structures. And it does that through 4 different phases. So the sclerotomal phase, basically the sclerotomes are migrating to the spinal cord region and they're remaining segmented. But during the precartilaginous phase, these sclerotomes, so they're going to divide into cranial and caudal sections. And this is going to allow the spinal nerves to pass between them. Okay, so this is the reason, why the spinal nerves exit between the vertebrae or how it happens. And then your third stage is the cartilaginous stage. And each portion here, so the centrum, the vertebral arch, and the costal processes are going to give rise to different bony structures. I don't remember a specific question about this, but if you have time, make an attempt to learn this. But I'm not sure that this was like super high yield. I know this right here is a lot. I would more just have a broad idea of what is happening in each stage. And then, of course, in your fourth stage, this is the bony stage, and you're getting primary ossification. And then secondary ossification is going to form or occur during puberty. All right. So know the 4 stages and have a decent idea of what is going on in each stage. Okay, so the skeletal system development. So 2 things to know here. The first thing you want to know is that so when the fetus is born, or when you have a newborn, the long bones are formed, but only a few of the epiphyseal centers have begun ossification. So this is going to be the distal femur and the proximal tibia. So just in case he asks you that, just kind of a factoid, you need to know it. And then achondroplasia, I honestly don't remember if this was specifically on the MGA exam, or maybe you've already been asked about it in MFM, but you're probably going to be asked about achondroplasia on exams like more than once. So achondroplasia happens due to premature ossification at the epiphyseal plates of long bones, and so the presentation is going to look like these images over here. So you're going to have like a normal sized trunk and head, but the limbs are going to be shortened. Okay, the next one, this is another maybe. We were definitely asked about AMC at some point, but I'm not sure if it was MGA. So AMC, basically during development, limb movement is going to be required for normal joint development. So if this doesn't happen, then you're going to get joint and muscle contractures, and that's going to lead to arthrogryposis multiplex congenita. And in this condition, the joints can be contracted either in a flexed or extended position. There really isn't a pattern to it, so like you can see a presentation, with one wrist flexed and one extended, and so on. But the main thing to know is just that this is going to present with joint contractures. So if you see a patient with a lot of joint contractures, think AMC. Okay. So when I listened to his lecture, he said that he was not going to test on this because Dr. Chesson gives a lecture describing this, and I mean, I honestly can't answer that for sure, but I would assume so. Yeah, that would make sense to me. So he said that he wasn't going to test on this because Dr. Chestnut gives a lecture on it in second year, and I would say that is true. So if you feel like you can trust him, you could X this out and not worry about it. But the 2 I feel like he is most likely to ask about is going to be Klippel-Feil syndrome. So this patient over here has Klippel-Feil. So if you see like a short web neck, or if that's described in a question stem, okay, so think Klippel-Feil, and that's due to excess retinoic acid. And then spina bifida. Have you guys been tested on spina bifida yet? Yes, no? Do you remember? No? Okay, so this is a possibility. So spina bifida results from a failure of the neural arch to form. And I think the one that he focused on was spina bifida occulta. So that's the most common one, where you have a failure of the bony structures in the neural arch to unite. And then, extra ribs, just know that this is a possibility. And the extra cervical rib is probably most concerning because you can impinge on the brachial plexus. Okay. I definitely remember a test question about the AER versus the ZPA. So what this is talking about is a limb bud formation. So if you know that the AER directs proximal distal limb development and the zone of proliferating activity directs anterior posterior limb development, that should be good enough. So my trick here, so ZPA, PA, posterior, anterior. So hopefully that helps. And also, I believe this was one of his questions, the difference between polydactyly versus syndactyly. So make sure you know these clinical correlates that are just definitions, like that's easy points. So polydactyly, you're gonna have multiple digits, and then syndactyly, you have webbing of the digits. Okay, so limb malformations. I mean, this is a maybe, so you can get congenital amputations if you have amniotic bands wrapping around the limbs. But the question I remember from last year, it was right here. Okay, so definitely know those definitions. So amelia is the absence of limbs. Meromelia is the absence of limb segments. And then phocomelia is the absence of proximal structures. So you can see over here how this baby has hands and feet, but the arm and the forearm itself is missing. All right, so know these three. All right, is everyone? What do you mean by missing segments? Oh, okay. So I believe what he meant is just that, like, portions of the arm and forearm could be missing. Let me look that up really fast just to make sure. And while I do that, we can go forward and start with this first practice question here. So go ahead, if you guys know the answer, go ahead and type the answer into the chat box. Okay, yeah. So I looked it up to make sure, and meromelia means that you're lacking just a part of the limb, but you still have the hand or foot present. So let me go back here. Okay, so amelia, you have no limbs whatsoever. Meromelia, you see how it looks like she's like missing a forearm maybe? So you're missing just a segment. And then phocomelia, you're completely missing the proximal structures in all four limbs. So just hands, just feet, no arm or forearm. Okay, so these practice questions, I got these from, yeah, you're welcome. I got these from BRS Embryo. If you guys, I know like Embryo tripped a lot of people up last time, but like I really really feel confident that if you just learn the slides I have, you'll be fine. But if you feel like you need more, like I'm happy to send you a copy of the BRS embryo if you don't have it. So just send me an email if you need a copy of that. But that's where I got these practice questions from. And most of the practice questions in BRS, they were revolving around the whole anterior posterior condensation concept. So yeah, I mean, that I guess is board relevant. So I would definitely expect questions from it. Okay, so yeah, Johnny, you were correct. The answer to this one is the anterior condensation. So the biceps brachii is a flexor and it develops from the anterior condensation. How about the biceps femoris? So the answer to this one is actually C, and that's because of the rotation that's going on. So you remember how the upper limb rotates laterally, and then the lower limb rotates medially. So that's going to put this flexor in the back, so it's part of the anterior condensation. Okay, how about this one? Remember your bony structures, where are they coming from? Don't be afraid to take a guess. Or look back at the slides. So, yeah. Oh, yeah. Yeah, they're posted on my Google Drive. Did anyone see the slides? Or was anyone able to access the slides? Yeah. Yeah, so the answer to this one is B, so lateral plate mesoderm. Okay, well, so long head of the triceps develops from which of the following? So Johnny says A. Right, that's correct. Okay, next. Which of the following muscles will the lateral cord of the brachial plexus innervate? So throwing it back here. I doubt he'll ask you like a question that's like strictly brachial plexus, but just to review, I guess. Okay, so the answer is E because of the musculocutaneous nerve. All right, this one's not bad. So how is the upper limb going to rotate? All right, good job. So the upper limb rotates laterally. And how does the lower limb rotate? Medially, right? Okay, rectus femoris. It's developing from. I think somebody has their mic unmuted. Right, good job, you guys. Posterior. Okay, and then number 5, we went over this one. So the lower limb is rotating. Medially, right. All right. So if you were confused on any of these questions, go back here. Go back to this slide right here. Second. Three. Sorry. Oh, the second to last. Okay, hold on. Was it this one? Was it this one? Okay, did you have a question about this one? Oh, yeah, so the answer to this one is A. And I think the lower limb questions are a little bit more confusing, but think about the rotation and where that's positioning the compartment. So just spend some time looking over this right here. And then if you were confused at all, try those questions out again. But I actually remember probably like at least two questions coming from this like concept right here. Okay. Is everyone good? Yeah, you're welcome. If everyone's good, that is all I've got for you. So good luck studying. Yeah, you're welcome. Let me go back. Yeah, I looked again. As soon as I get done here, I will double check and actually like send me a Facebook message if you like. Let me double check once we get done, and if you like still can't find them, send me a Facebook message so like I know your actual name, and I will send them to you if you still can't see them. Okay. Yeah. Okay. So humerus and lateral plate mesoderm. Yeah, so that's actually a good question because when I saw that, were you thinking it would be sclerotome? Sclerotome? Because I was. Yeah. Let me look again what the explanation said. Humerus. Humerus, here we go. Okay. Oh, so I'm guessing that the upper limb bones must develop from a lateral plate mesoderm, and then the lower is from sclerotomes, because I noticed, so when he talks about this, he only talks about lower limb bones, but honestly, like he didn't really specify that, so I wouldn't worry too much about it. How do you know that rectus femoris is from the posterior condensation? Hold on just 1 second. Yeah, did the question say biceps femoris? Is that what you're saying, Johnny? Okay, so right. Yeah, Tyler is correct. I don't think he'll ask you one that has a dual action like that. Let's see. Where was it? Biceps. Okay. Yeah, I wouldn't. I mean, I think his question will be more straightforward. Like if it has two actions, um, yeah, I don't remember anything like that on the exam last year. Like he would be like more likely to ask you about the triceps or something like that, where it's a lot more obvious. Yeah, no, you're good. You're good. And I'll think about that. If I could come up with any better explanation, I'll post it in the comments. In case if we don't remember the function, I'll post it in the comments on Facebook. In case, is there any way to figure out? Ooh, um, no, you really have to know the action to be completely honest with you. I mean, but worst case scenario, it's one question. So don't kill yourself trying to um, go and relearn all of upper limb. I don't think he's going to be that tough on you. Like I think he'll probably give you one that you're more likely to know, like the triceps, extension, biceps, flexion, something like that. All right. Well, if you guys don't have anything else, I'm going to get off here.